Good morning, everyone, or afternoon, wherever you are. Welcome to our webinar today entitled NOMO FOMO 2026. In case you missed it, recent changes in guidelines, new publications, and updates from recent conferences. I'm the moderator of this session today. I'm Constance Benson. I'm a professor of medicine at the University of California, San Diego in the Division of Infectious Diseases and Global Public Health. I'm joined today by our presenter, Roger Badimo, who's a professor of medicine at the University of Texas Southwestern Medical Center. Dr. Badimo is a interim director of the Global Health Office at the University of Texas Southwestern Medical Center, and he's also the chief of infectious diseases at the VA North Texas in Dallas. He's currently a member of the IAS-USA Guidelines Committee, and with the success of antiretroviral therapy and improved survival of people with HIV, non-AIDS and especially age-related complications are becoming the greatest cause of morbidity and mortality, and his research focus has been on understanding the risk factors, determinants, and mechanisms of these complications, including non-AIDS malignancies, cardiometabolic risk, decreased bone health, and focusing on co-infection with chronic hepatitis C and the natural history of disease related to the COVID-19 pandemic, with a special focus on post-acute sequelae. So we are going to move on to some of our housekeeping details before we get into the actual talk today. But let me first start by telling you about financial disclosures. These are the financial disclosures for the content on the web, individuals, and financial relationships with ineligible companies for Dr. Badimo and for myself. Just a little bit about the CME credit for our program today. The IAS-USA designates this live activity for a maximum of 1.25 CME credits, and in addition to that, also has 1.25 hours of ABIM mock points and nursing, pharmacy, and pharmacotherapy credits. I'd just like to thank some of the contributors for their generous support for this activity, and this slide indicates the contributors to our program today. A few points about navigating the webinar. We will be showing you a separate window that will have the poll questions for today. Our chat is open for general discussion among the attendees, but the presenters and moderators will not see the chat. So please submit all of your questions using the Q&A button. And we will only respond to questions that come into us through the Q&A button. We apologize in advance if we're not able to address all of your questions in the allotted time, but we'll do our best to do so. So I'm now going to turn the program over to our demographic questions. Here are the responses. You've all kindly answered these questions. You can see that the majority of our attendees today are medical doctors and pharmacists, with a good representation of physician assistants, nurse practitioners, nursing professionals, health educators, and other. So thank you all for joining us today. We're looking forward to a spectacular program, and I'm now going to turn it over to Dr. Badimo for our presentation today.
Thank you so much, Dr. Benson, for the kind introduction, and welcome to all of you to this webinar. And I will now proceed on to present what we have prepared as NOMO FOMO, in case you missed it, recent changes in guidelines, new publications, and updates from recent conferences. And this is my name, and these are my disclosures that Dr. Benson just went through. What we intend to do in the next hour is to describe notable changes in guidelines designed to optimize the care for people with HIV, summarize recent data on prevention and management, and describe recent development of non-AIDS complications, including cardiometabolic risk and the ever pertinent issue of weight gain. And then finally, we will incorporate evidence-based recommendations in the management of the cardiometabolic risk of people with HIV. Start with this first question. It's a 68-year-old man who was diagnosed with HIV 10 years ago. His baseline plasma viremia was 1.2 million, and CD4 count at baseline was 122. He's now virologically suppressed on stable integrase inhibitor-based regimen. His CD4 count has risen to 640, and his comorbidities include type 2 diabetes, hypertension, atherosclerotic cardiovascular disease, and he has had an acute myocardial infarction 3 years prior. Also, for good measure, has prostate cancer. So this is the patient who's coming soon to a clinic near you. Let's what you have as answers here. Number one, his high plasma viremia and his low CD4 count would predict failure of a treatment based on dolutegravir and lamivudine. B, he will have an increased risk of biologic failure if he was to be switched to lenacapavir bictegravir for continuation of his ARV therapy. That's an increased risk of weight gain, but no change in cardiometabolic outcomes on INSTI-based ART. And finally, D, he would not see any meaningful change in his weight trajectory if he was to be switched from INSTI to rivaline-based regimen. So let's see what answers you have, and then we will pause a little bit to see if we can address a technical challenge we face. Okay, I see the answer here. The answer of 45% of the participants are saying that they do not expect any change in its weight trajectory based regimen. So let's see. Second question here is somebody who's 27 years of age and recently diagnosed with syphilis, and an HIV test was negative. He was also recently exposed to a person with active tuberculosis and presents to care with cough and shortness of breath. Of course, concerned given that recent exposure. He's worried about his risk for HIV, for STIs, and other infections, and is interested in any on HIV prevention. So which of the following statements is correct and can inform this patient's care? A recent analysis in Africa of integrated HIV pre-exposure prophylaxis, PrEP, and post-exposure prophylaxis, PEP, choices with self-assessed risk of HIV acquisition. Now, this study showed that poor adherence and cost effectiveness was demonstrated in that setting. B, analysis of HIV prevention studies over the past 15 years suggests that HIV incidence has declined. C, doxycycline pre-exposure prophylaxis substantially decreases the risk of syphilis and chlamydia with no significant increase in tetracycline resistant and syphilis.
Excuse me, Dr. Badimo?
Yes.
Your audio is, we're having some problems with your audio. Can you please go off camera and we'll see if that helps?
Let's see. I apologize. That was really working when we tested. So how about now?
It sounds a lot better, actually.
Okay. Yeah,
Great,
I apologize that bandwidth just decreased. So for those who were not able to follow what I said earlier, we just went through 2 pre-test questions in the interest of time. I hope that we can proceed without revisiting those questions, but the answers will be clear during the presentation. Apologies for the technical glitch here, and but the second question was looking at testing and pre-exposure prophylaxis and prevention of diagnosis of opportunistic infection in somebody who has recent exposures. And we see here that the majority of attendees find that the stool testing would improve the yield of tuberculosis diagnosis in this person. So let's proceed and see how the outline is. We would expect to visit something about custom design or so-called dynamic choice in HIV prevention, a new study that was done in that regard. And then we look at the management of both treatment naive and treatment experienced patients. And we will look at dolutegravir, lamivudine, in a new setting that has been that people have been accustomed to, as well as cabotegravir ripivirine in people with advanced CKD. We then looked at oral bictegravir, lenacapavir. For prevention and management of opportunistic infections, we like to look at doxy-PEP, as well as potential off-target effects of that modality, and then diagnosis of tuberculosis in people with HIV and without. And then finally, HIV-HBV co-infection. We will conclude with the non-AIDS complication and survival of people with HIV, focusing mostly on cardiometabolic risk and weight gain. So let's first look at where we stand in the ending the HIV epidemic initiative. Are we on track? We were planning to, even before the current environment of funding challenges. And then we'll look at the dynamic choice in HIV prevention and a nice study that was done in Africa. So this is the ending the HIV epidemic as was presented several years ago. What I would like to reiterate in this initiative is that the importance of it was that it was not an all size fits all. It was a targeted approach to diagnose most people with HIV, to treat them, to prevent new infection, to respond quickly to potential outbreaks. And it was acknowledging that half of the incidence of HIV in this country was in 50 counties and 7 rural states. And if you focus on those, you will have a much better impact. Now, if you look at the world as a whole, we were planning to control the epidemics by 2030. This is a mere 4 years from now. And I guess it would be no surprise to anyone here that the current efforts were found to be insufficient. And this was before the funding challenges. So we are facing a significant concern that the HIV epidemic will be a lot worse than it is today. And to find out, this study looked at HIV incidence rates in the placebo arm of several HIV prevention trials. Of course, an HIV prevention trial today will no longer have a placebo arm because that would be unethical. But when it could, there was no significant decline in the incidence of HIV over several years. And so we don't know that that trajectory will head out in any positive inflection anytime soon. So that's why to mirror the targeted approach of the ending HIV epidemic in the US was this dynamic choice of HIV prevention study that was started in Africa. The dynamic choice, what that means is that there is an integration of pre-exposure prophylaxis, PrEP, with TDF-FTC, as well as post-exposure prophylaxis and in people who were found to be exposed during that intervention, as well as a self-assessment risk of HIV acquisition. So people who were enrolled were asked to assess their own risk. If they had not been exposed, they were given PrEP, offered PrEP. If they were exposed, they were given PEP. And then also they were given biomedical interventions like, they were given condoms as an option. Now, when long-acting injectables were ushered in, they were added to the PrEP choices. What they described as biomedical cover time was the proportion of time that the participants spent being protected from HIV, either by PrEP or by PEP. And this was higher, significantly higher, in those who opted for this dynamic choice, i.e., almost 70% of the time somebody was being protected, compared to the standard of care, which was only 13% of the time. More importantly, the HIV incidence was negligible in those on dynamic choice prevention versus 1.8% in the standard of care. So the graph here shows the changes, the differences in time that the patients spent protected, the participants spent protected. And here you see the menu. Essentially, people were given a lot of choice. And a product choice, the pre-exposure prophylaxis in green versus post-exposure prophylaxis, of course, if they deemed that they were exposed, with or without condoms or no intervention at all. They were offered to either self-test in red or get the rapid test in yellow. And also, they were offered a choice of where the prevention activities would happen, either in clinic or at the community side. So this intervention likely was found to be significantly cost-effective among multiple settings in East, Central, Southern, and West Africa. And it's something that can actually inform what we could do here in the US as well. Now, again, this is just to show that dynamic choice may reduce incidence in Africa, especially when you add cabotegravir as an option, which was not available when this was started. Now, let's look at the progress in management of people who already are living with the disease, whether they were treatment naive or treatment experienced. This is, if you remember, that is just a trip down memory lane before the integrase inhibitors were developed. Protease inhibitors were where people were advocating for in people with advanced disease, very low CD4 count, very high viral load, as the potency of the protease inhibitors was deemed to be superior to what was available at the time, non-nucleoside reverse transcriptase inhibitor as an alternative. Now we do have most patients studying integrase inhibitors, and it was important, as was done in this multi-center study in Europe, to compare protease inhibitors, in this case, darunavir, cobicistat, FTC-TAF, with integrase inhibitors, in this case, bictegravir, FTC-TAF, in people with advanced disease. As you can see here, the mean CD4 count here was 41, and it was found that INSTIs were non-inferior to PI in the primary outcome, which was time to virologic and clinical event, but with fewer adverse events. This is really reinforcing or justifying the guidelines today that most people should be receiving integrase inhibitors, and that should extend even to people with advanced disease. Now, for those who were already suppressed on the initial antiretroviral regimens, if they were to be switched to a standard a single tablet regimen of bictegravir and lenacapavir, as was done in this Artistry-1 study. It's a small study looking at adults of living with HIV who had achieved suppressed viremia on complex antiretroviral therapy for more than 6 months, and they were randomized to switch to bictegravir, lenacapavir at 2 different dosing regimen, or remain on the complex regimen. You can see here that 40% were taking ART at least twice a day more, and there were 43% were taking 2 pills a day, 19% 3 pills, and 40% 10. 11% 4 pills, and some were taking 5 or more. So these were complex regimens, and when they were switched to STR, bictegravir, and lenacapavir, the virologically outcomes were non-inferior. So it's important that we begin to consider simplification of antiretroviral therapy in our participants who in our participants who are on complex regimens, even if they're virologically suppressed. So, and this is to remind you what the IAS-USA guidelines will say today as recommended for most people with HIV, and is essentially integrase inhibitors-based regimen, bictegravir, FTC, TAF, dolutegravir plus FTC or 3TC or TDF or TAF. And then dolutegravir 3TC only in participants who, in patients who have a viremia of less than 500,000. This is a legacy of the registration studies called Gemini 1 and 2, which limited enrollment to people who have a viremia of less than 500,000. And in red here, there was limited data on using DTG 3TC for initial therapy of people who had CD4 count of less than 200 as well. So enters this Dolce study, which was designed to address exactly that question. That was used in people with CD4 count of less than 200, randomized to dolutegravir 3TC or triple therapy. And the conclusion, to cut the long story short, is that dolutegravir 3TC demonstrated high efficacy in these people with low CD4 count and high viral load. Essentially, people who were either not advised to take this regimen per guidelines or advised caution should they take it. And this is the summary of the findings here. The mean CD4 count, the median CD4 count in this study was a paltry 100, and almost 2/3 of the participants had a viremia of more than 500,000. Essentially, people were excluded from the Gemini study. So this study begins to give confidence in that regimen in people with low CD4 count or high viral load. And then we have the question of people with advanced kidney disease. And since we're beginning to use long-acting injectables for many of our patients, it's important to see if that option would be available to people with CKD. And we know that cabotegravir is primarily metabolized through the UGT, and most of it is excreted to feces. And the same thing with rilpivirine. So, and then both drugs are highly protein bound, so it's not very likely that dialysis will impact it. So that's why the CAPRI study was important, to see if this is indeed the case, where 12 participants, this is a phase 1 study, with CKD 4 or 5, with or without hemodialysis, were virologically suppressed, were switched to cabotegravir monthly first, then every 2 months. And the long story short is that while the trough concentrations of cabotegravir rilpivirine were primarily within the therapeutic range at week 48 in these participants, virologic response was maintained, and there were no changes in immune response. So it's a good first study to show that it's actually possible and it will be safe and effective to switch people who have advanced CKD to cabotegravir rilpivirine. Now let's look at prevention and management of opportunistic infections and co-infections in people with HIV. And we look at population effects of what the doxy-PEP would have, and also tuberculosis prevention and treatment, and then finally co-infections with hepatitis B and prevention of pneumonia and herpes zoster. So here is what was published over 2 years ago, almost 3 years ago. The doxy-PEP study was a game changer. that with 500 participants or so randomized to receive doxycycline 200 milligrams within 72 hours of a condomless sex or standard of care, the doxypep significantly reduced the incidence of several of these STIs. So this was a significant development. And there was also Doxyvax, another study done that we will not discuss here. But this is just to show you that this study begged a real life experience, which was now provided in two different studies that I will present. First, the Kaiser Permanente in Northern California retrospective cohort showed that among doxypep recipients, quarterly chlamydia positivity decreased by a whopping 80% after starting doxypep. And this is what you see here. And then also quarterly rectal and urethral gonorrhea positivity also decreased, but importantly, not pharyngeal GC. Now, pharyngeal GC seems to be a specific beast. That's why it's important to do a test for cure when you have a pharyngeal GC. And finally, in the same study, quarterly syphilis positivity also decreased similarly by 80%, while positivity for STI remained stable in individuals who did not receive doxypep. So that's a very, very positive, real-life confirmation of what doxypep studies showed. And another real-life confirmation was in San Francisco, where we see that the cases of chlamydia and early syphilis decreased by about half when doxypep started being used. Again, you see at the bottom here, GC cases did not decrease. So it's important to be cautious about the impact of GC of doxypep on GC cases. Now, not clear how to unpack the fact that doxypep did not decrease GC cases in this study, but it's important to think about possibility of tetracycline resistance, and not just for GC, but for other organisms. This is what this new study showed, the potential off-target effects of doxypep, not PrEP, sorry, in the prevalence of tetracycline resistance among men with NG infection. So National gonorrhea in King County, you see that there was a trend for tetracycline resistance in National gonorrhea, and that there was association of the doxypep use with NG tetracycline resistance. More importantly, tetracycline resistance in NG rapidly increased from 2021 to 2024, and most National gonorrhea among King County MSM now has this high level of resistance. So that's important. Of course, that may tie in with a somewhat mild or no decrease in cases of NG. But the most important thing is that off-target, is that tetracycline resistance was not limited to Neisseria gonorrhea, but doxypep use was also associated with colonization with group A strep and tetracycline resistant Staph aureus, suggesting that this doxypep might have off-target effects. So then I would look at a prevention of tuberculosis in people with HIV. First, we have this dolphin mom study that was presented at CROI, which is like dolutegravir dosing, was considered acceptable in 5th percentile DTG trough if the 5th percentile DTG trough was over 158, this line here. So that is what you expect to result in good enough exposure of dolutegravir. Now, what happens then if you give people INH rafamycin, or so-called 1-HP daily for 1 month, or 3-HP weekly for 12 weeks. Simulations predict that the once daily dosing will achieve target dolutegravir concentrations with the 3-HP, which is weekly for 12 weeks, but not with the 1-HP, which is daily for 4 weeks. So that was important as we move forward to prevent reactivation of TB in people who are pregnant. Now, these are the recommendations as of 4 months ago in the DHHS guidelines. When you're using dosing recommendation for antiretrovirals in people who are also using anti-TB drugs for prevention. So I would highlight only those were in the rafamycin and INH regimens, 3-HP every week for 3 months, or 1-HP daily for 4 weeks. You will see that it's only the only recommended ARV in the DHHS guidelines will be efavirenz and NRTIs with a caution for TAF. Now, no other ARV is recommended, but that doesn't square well with the fact that most people are receiving INSTI-based ART. So that's why this Dolphin 2 trial is very important, because what they use is initiation of dolutegravir-based ART in INH rafamycin and INH rafamycin in ARV-naive people with HIV. And this is a non-randomized trial of 75 ARV-naive people with HIV without active TB were assigned to 3 months weekly or 3-HP or 6 months INH, which is the alternative here. And so the important finding is that when they looked at the PKs of dolutegravir at day 1, at week 3, and at week 8, as you can see in the graph here, all dolutegravir trough values were higher than what would be predicted to be adequate exposure, as shown as the dotted line at the bottom here. So this is reassuring that you don't need to change the dosing when you using this 3-HP modality. Now, again, this is what shows here. Despite somewhat lower levels of dolutegravir-based ART, it was safe and achieved therapeutic concentration. So DTG dose adjustments are not needed if you use this modality. So we expect this to be reflected soon in recommendations that will be issued. So now, when you already have a concern for TB development, now diagnosing tuberculosis has a lot of drawbacks. It's just not sensitive enough, regardless of what people think. So the study evaluated the diagnostic accuracy of adding stool expert TB, or also called stool ultra, to what modalities are used today. And this is when compared to the standard of care, or the gold standard, which is by the WHO called composite microbiological reference standard. Now, this convoluted term simply means that the testing accuracy is poor. So what they use as a gold standard is a combination of urine TB lipoarabinomannan, or LAM, with a sputum nucleic acid testing, expert NTB, and sputum culture, or that composite is the gold standard. So to test anything, whether to assess whether it improves diagnosis of tuberculosis, you have to compare it to that gold standard. That's what was done in this study. Sputum ultra and stool ultra were compared to that composite standard as well. So finally, they calculated the diagnostic yield that testing TB in stools would add. And so what you see here, these are 677 participants were enrolled, and tuberculosis were confirmed in 119 of them. So this was a very high pretest probability of TB in these participants here. So 39 or 33% has a positive test with sputum, and 30 or 25% had a positive test with culture, and 84 of them, 71% had a positive test with urine. So the diagnostic yield of any of those available modality is substandard. And then stool ultra resulted in additional cases detected of 23% compared to sputum ultra. And so the overall diagnostic yield for all treated, all tested for stool ultra was 9%. It might not sound a lot, but it improves what we have today. And TB LAM was 12%, and sputum ultra was 6%, and then sputum was 4%. So this is important to kind of remind ourselves that diagnosing TB, if you have somebody who has a high pretest probability based on epidemiologic factors or others, negative tests should not dissuade you from considering TB diagnosis, but these two tests may just add a little bit. Now let's look at hepatitis B co-infection in HIV. The Alliance study started a few years ago and has already had some yield. This is adults with HIV and HBV with no previous HIV/HBV treatment. The idea is to see, essentially compare the two formulations of tenofovir, TDF and TAF, and on a number of outcomes in people with HIV-TB co-infection, whether it's HIV virologic suppression, HBV virologic suppression, ALT normalization, or seroconversion of these two antigens, HBe antigen or HBs antigen, as well as changes from baseline for metabolic parameters or renal parameters to look at the safety of these two modalities. Now, many of this data has already been published for the HIV RNA and HBV RNA changes. What this particular analysis looked at is whether prior HBe antigen status at baseline had an impact on those outcomes, and it did. So baseline HBe antigen negative status was associated with a higher likelihood to suppress HBV DNA. And also at week 96, there were higher rates of seroconversion of HBs antigen, ALT normalization with TAF than with TDF in both HBe antigen positive and HBe antigen negative people at baseline. So it's important to consider TAF probably more than TDF in people who are co-infected with hepatitis B for all these reasons. Then another thing about one size does not fit all, number one. Number two message in this particular study is that if you just have people on HIV therapy, you will prevent a lot of the AIDS-related complication, even if the CD4 count is not quite elevated yet. So here's the incidence of community-acquired pneumonia and herpes zoster in people with HIV based on CD4 count and age in the current ART era. So it's an analysis of the incidence rates of CAP and herpes zoster in the Athena cohort in the Netherlands. And so from 2010 to 2023. Message number one, you will see here that the incidence of community-acquired pneumonia is lower, significantly lower, even with a low CD4 count as soon as you start antiretroviral therapy. So compared to no antiretroviral therapy in blue, the incidence of community-acquired pneumonia is significantly lower, even with less than 1 year on ART in green or more than 1 year in red. Again, even if the CD4 count is still very low. And of course, things get a lot better if CD4 counts increase. The second message is that if you look at people who are much more likely to develop pneumonia, i.e., older than 60, and more likely to develop zoster, i.e., older than 60, compared to the general population, which is the dotted line on both curves, if you do have a CD4 count of over 200, your risk of developing either pneumonia or zoster is not significantly higher than that risk in the general population. So it allows you to probably calibrate the stringency with which you apply those preventive modalities in your people with HIV. Now, we'll finish in the last section of the talk, which is also the largest, with non-AIDS complications of HIV disease. Why the largest? Because that's what drives the most morbidity and mortality today. The first message is that we are still underestimating that risk. We've used any of the risk equations that we have at our disposal today. We started with the Framingham risk score, and then we moved on to the so-called pooled cohorts equation. In both cases, the incidence of cardiovascular diseases in people with HIV is a lot higher than what these equations predict. Now, that would make sense because HIV is not included in the formulas of these equations. Enters the newest kid on the block, which is the PREVENT equation, just rolled out last year. The PREVENT equation adds a number of things that the pooled cohorts equation did not have. Number one, it starts predicting the risk at 30 rather than 40. By the way, if you look at applying the findings of studies like REPRIEVE, you will be stuck if somebody with HIV comes to your clinic and they're 30, because that was not included in REPRIEVE because the equations were based on 40 and above. Now, PREVENT solves some of that by lowering that age to 30. It does two other things that are highlighted here. It predicts not just cardiovascular disease, but also heart failure. The second thing is it includes social determinants of health. As we know, they are bona fide risk factors for cardiovascular disease here. The bad news is that it underpredicts these events in people with HIV even more than the previous pooled cohorts equation. And this is presented in two different studies here, one by Dawson's-Feld, and then the other one is analysis of the REPRIEVE, which is the gift that keeps giving. Unfortunately, these two graphs are flipped. Here, the dots at the bottom of this diagonal means under prediction. Here on top of here means under prediction. So the PREVENT equations significantly under predicts ASCVD risk in people with HIV. So we need to be cognizant of that when we look at people. So the color coded the impact of statin therapy. So you will see here that if you were to follow the PREVENT equations, you will not initiate statin in a significant number of people who are at high risk. And the same thing here is that the observed incidence of major adverse cardiovascular events was higher than predicted by the PREVENT equation, except for the ultra-low predicted risk. So that leaves us in a very difficult predicament. When we have people with HIV in front of us, we know that the morbidity is likely to be driven by and large by these non-AIDS complications, but we're not very well served by the equations that we have. Needless, be that as it may, these are the recommendations we have that we need to be aggressive in using statins per the guidelines, per the findings of the REPRIEVE trial, i.e., as low as 5% risk by pooled cohort equation. Now, the reason why these equations don't predict cardiovascular disease in people with HIV as well as others is because, of course, the pathogenesis of these complications, whether it's cardiovascular disease is highlighted here, but all the non-AIDS complications derives from three sets of factors: patient factors, the viral factors, and also potentially the treatment factors. So these number 2 and number 3 are not entered in the equation, so we need to be cognizant of that. This is what leaves us scratching our heads even more. So now that we have some suggestions in some studies, like the RESPOND cohort in which is a prospective multi-center collaborative study in 17 pre-existing European cohorts and Australian cohorts, which shows that INSTI initiation was associated with an early onset excess incidence of cardiovascular disease in the first 2 years of exposure. For those of you who have been in HIV care for longer than 15 years, this will be reminiscent of what we had with abacavir several years ago. And also reminiscent of the situation of abacavir is the conflicting findings as this other target emulation trials for HIV, COSA and RCC did not find any increased risk of ASCVD events with INSTI use. And I can say that the Swiss cohort showed the same thing. So we need to now be mindful of the fact that the data is still a little bit fluid, and we need to disentangle all these studies to see what the kernel of truth is. And again, we have here association of ART and cardiovascular events in people with HIV. The risk of MACE in this analysis here, or major adverse cardiovascular event, was higher with both protease inhibitors and INSTIs. So again, one of the things that we're concerned about in a weight change in people with HIV is that it might drive cardiometabolic risk, increased cardiometabolic risk. So I'd like to kind of put a caveat here that in this analysis of the much cited paper of 8 phase 3 RCTs of first line ART, that looked at the risk of the magnitude of weight change with INSTIs, which was greater than PS and NRTI, and with TAF, which was greater than the other NRTIs. It's important to say that not everybody gains weight. In fact, this is a verbatim excerpts from that study that through 96 weeks, there were only maybe 17% of people who gain 10% or more weight, 36% who gains 5% or more, and weight gain was not observed at all in 30% of the it was not observed in all participants, and 30% lost weight. Now, it's maybe possible because one of the comparators here was AZT, which is maybe associated with weight suppression as well as some NNRTIs. Now, weight gain has been a significant conundrum in our care now, because most people that we recommend antiretroviral therapy initiation with, we recommend it with integrase inhibitors, which are what have been associated with weight increase. Now, the PASO doble study looks at dolutegravir 3TC compared to bictegravir FTC TAF, and to see if there's any meaningful difference in weight trajectories, which they found. And I will put a caveat here that not all studies have had similar findings in differences in weight trajectory. But here we have dolutegravir 3TC compared to bictegravir FTC TAF, and differences in weight trajectories from a baseline to week 96 in this study. The question now is that for people who gain weight on antiretroviral therapy, whether it's an integrase-based regimen or not. Is there anything that can be done? Now, of course, we've had several studies, and I will show you some of them later, but this is the latest one presented at IAS-USA in October, where obese people, a BMI of 30 or more, on raltegravir, dolutegravir, or bictegravir, were randomized to either switch to doravirine plus TAF-FTC or doravirine plus TDF-FTC, or continue where they had. The bottom line is that there was no significant difference in weight trajectories for those who remained on INSTI-based or TAF-based ART, or those who switched to either arm 1 or arm 2. What I would like to point out here is the median time on current INSTI plus TAF was 3.4 years prior to the switch, okay? And 13% were taking dolutegravir, 1% tegravir, and all with TAF-FTC. So median time prior to switch was 3.4 years. Now, if you've seen this data ever since we started talking about weight gain, you will realize that most weight gain occurs in the first year of therapy. And the weight trajectory is either plateau or really the slope of increase is much lower after that. Therefore, regimen changes after that 1 year, in my view, would have a certain impact on weight trajectories. And so 3.4 years in the DOE trial, and I can show you all the other trials, or many of the other trials that have been published thus far to see no difference in weight trajectory with switch. The median time on prior ART in month is in 60, 30, 30, 20, 14, 24. All after 1 year. So it's important to take that into consideration when you look at those studies. Another thing that you have to take into consideration when you look at switch studies is that our expectations of change in weight trajectories with antiretroviral switch should be tempered by the fact that there are other factors than antiretroviral drug choice that impact weight trajectories, and some of them are viral or immune factors that should always be put into consideration. So this is why the guidelines, the DHH's guidelines from 3 or 4 months ago, say specific antiretrovirals should not be selected to prevent or reduce weight gain, as available evidence suggests this strategy is ineffective. So other things that switch would not do for you is improve inflammatory or metabolic parameters, as this newer study has shown and still not in print yet. So weight changes were modest and no relevant differences were found in lipid, glucose, eGFR. But concerning is that studies are suggesting some real cardiometabolic risk of switch to integrase inhibitors. And since few studies have explored this cardiometabolic change beyond 2 years, it's important that in the REPRIEVE trial, the estimated hazards for most of these outcomes were elevated in analysis restricted to female participants, particularly major adverse cardiovascular events. So it's important to be cautious about potential increase in obesity, diabetes, hypertension, even if MACE was not seen in most people over 3.4 years after initiation or switch to INSTIs in REPRIEVE. More data will likely come out from from other studies. Now, the risk of hepatocellular carcinoma, if there was any other reason to treat hepatitis C in people with HIV, is that years after treatment, you have a meaningful evidence of decline in incidence of HCC after treating hepatitis C in people with HIV. But we have all seen this graph during earlier training with HIV, is that you get infected, your CD4 count is still very high. You take a dip, you start antiretroviral therapy, it rebounds a little bit, but then over the years it goes down, and then viral loads is subsequently, eventually escapes control, and then you have opportunistic infections and you die. Now, this is not the trajectory of most people who are going to come to your clinic today, as you may agree. So what is likely happening is that the trends in life expectancy in older people with HIV has been significantly improving. And the population-based cohort now showing that, ever since the advance of PIs, the SMART study, and we have gradual narrowing of the gap in survival between people with and without HIV, with and without HIV. And again, since 2015, you see that starting treatment for everyone as soon as they diagnose, i.e. START study, has led to even further narrowing of the gap between the survival of people with HIV and people without, especially if they don't use drugs, especially if they don't have hepatitis C. So the price of success is that we now have a growing number of people on Medicare with HIV, and they're aging significantly, and so that number will be doubling over the next decade. And with that, the cost of antiretroviral therapy, which will increase significantly. The 10-year cost of Medicare anticipated to be over almost 200 billion, and if nothing is done. And I certainly do hope that something is done to decrease the costs and allow people to live long, healthy lives free from comorbidities, and be able to afford it, because those comorbidities will continue to accumulate, and over almost half of people will have 2 or more physical comorbidities, and 2/3 one or more mental comorbidities. And then these comorbidities, non-AIDS, cancers, and cardiovascular risk, are going to continue to drive most of the morbidity and the mortality. So this is what we're dealing with now, and I'm going to conclude with going back to these questions. So, and this is the first question we asked earlier. This is a 68-year-old man diagnosed with HIV 10 years ago, with plasma viremia over 1 million and CD4 count less than 200, and now virologically suppressed on stable integrase-based regimen, and also has all these comorbidities, cardiovascular disease, diabetes, and prostate cancer. So which of the following treatment is correct? His high plasma viremia and low CD4 count will predict that he's not going to do well on the tegavilamivudine. If we switch him to lenacapavir bictegravir, he's likely to not maintain virologic suppression. INSTI-based ART here would lead to increased weight gain, but no change in metabolic outcomes, no increased metabolic risk, or we will not likely see any change in the trajectory of weight if we switch to doravirine. Please go ahead and vote. Okay, let me see. Can we see the results? All right. Now we have 73% who chose answer D, which is the correct answer. Now let's move on to the next question. The answer D is because the intravenous the DEWIT trial shows that switching to doravirine based regimen does not alter the trajectory. So, and then we have other explanations for the false answers. The second question, let's move on to the second question, which is the 27-year-old person who is recently diagnosed with syphilis and HIV is negative, there's a lot of worries about exposure to tuberculosis, exposure to other STIs, and the like. So which of the following statements is correct to inform this patient? Is that dynamic choice HIV control with PrEP and PEP, it showed poor adherence is not cost effective. So that's number one. Number two, or B, is that analysis of HIV prevention studies over the past 15 years suggests that the incidence is declining significantly. Number C is that doxycycline PEP decreases the risk of syphilis and chlamydia with no significant increase in tetracycline resistance in Neisseria staphylococcus or streptococcus. And D is that stool testing would improve the yield of tuberculosis diagnosis testing. Please go ahead and vote. All right, so now we have 86% of people who chose the correct answer. And that correct answer is because this study among 119 patients confirmed that tuberculosis by composite compared to the gold standard CMRS, the stool ultra resulted in additional case detection, so increased the yield of testing. So thank you. I think that I will pass the baton back to Dr. Benson for moderating the Q&A.
Well, thank you very much for an excellent discussion. We'll just start by a brief apology to the audience for the technical glitches at the very beginning of your program. We're sorry the sound didn't work out until we got it fixed, but thank you all for hanging in there with us. Please do submit your questions through the Q&A button, and I will begin with the first question that was submitted. This has to do with your DoxyPEP presentation and a question about whether DoxyPEP covers oral chlamydia infections and what is the impact on oral chlamydia infection.
Yeah, this is a good question. Let me close my video again to see. So the Doxy PEP study used three-site testing. So the findings that we presented included all three sites. So the answer is yes. And I need to confirm that the Kaiser Permanente study or the San Francisco real life cohorts also did include three-site testing. I assume they did.
Okay, I'm going to start while we're waiting for the audience to address some of their questions. How successful or unsuccessful has PrEP been in MSM men and in women? And has PrEP fueled increases in other STIs aside from those discussed under DoxyPEP?
Yeah, this is two important questions. One of the sex difference in PrEP effectiveness. As you may all recall, the initial PrEP studies from IPREX to others were focused on men who have sex with men and transgender women and showing significant benefits. But then the FemPrEP and other ones in women, these show significantly lower effectiveness that led to hair scratching. Is that a biologic differences or is that an adherence issue? Now, with some studies plotting PrEP effectiveness in a specific study with the percent adherence that was seen in that study. But I think that more and more we have seen that this particular gender gap has been laid to rest. First, with the study that Jean Marazzo did in Africa, looking at uh, uh, you know the women on PrEP, suggesting that the same targets that led that predicted effectiveness, i.e., for oral PrEP being at least 4 doses out of 7 in the week, were the same in women. And then finally, we've had the trials by Gilead that suggested that is PrEP is just as effective if used adequately in women as it is in men.
Great, thank you. Another question that relates to doxypep, and how do you, this is more of an opinion question and your expert opinion on management, but how do you weigh the emergence of tetracycline-resistant staph, strep, and gonococcal disease with the benefits of doxyprep? How do you weigh those two in your mind when you're making a decision? And what's your advice
Yeah,
to
I
people?
joked when I last presented this data that there is the good, there is the bad, but there's no ugly. So it's important to say that it's on the balance. I would think that from the real world data that is accumulating, including the ones in Caso Permanente and San Francisco, that it's important to note that on the balance, there's significant beneficial effect of using doxypep, but we have to continue to track the not so positive effect, and that includes the tetracycline resistance on not just Neisseria gonorrhea, but now on strep and staph. Now, what would be the clinical impact of that resistance? Of course, is too early to say. So we need to follow up. And I think yes, that was my answer.
Great. Okay, thank you. Another question from the audience. Are there any studies known of in the US for the dynamic choice study you cited early in your talk?
Yes, no, there's no known study, at least not known to me, in the US on that. And I think that it's important that we follow up on that, because there's something beautiful about the concept. Is that people were not told one modality or another. They were presented several options, and they themselves identified the risk. If there was a recent exposure, then they were offered PEP. If there was no recent exposure, they were offered PrEP. They had opportunity to use it in clinic or in the community setting. And so there were a number of things that were beautiful about that design. And I expect it to work in other settings than in Africa where it was tested.
Okay, another question from our audience. Beyond statin treatment, how are you tackling the reality that our cardiovascular risk scores underestimate cardiovascular disease in people living with HIV? For example, should we consider referrals for stress testing for all patients over a certain age or some other intervention?
Well, yeah. So this is where I get to play the cardiologist on TV without a license. We, I would be lying if I said I know what we should do. But what we should know is that whatever patient is in front of us, their real risk is probably higher than what we see. Now, some people have suggested some formula to address that. And I'm not sure that those formulas have been well tested. So I would just say high index of suspicion. And right now, we no longer using drugs that we knew for sure are sort of increased risk, including abacavir and the boosted protease inhibitors. And so that's one thing that we can remove from that triangle of risk factors. Patient factors, smoking is incredibly huge, and it's even worse in people with HIV. Now, smoking is bad for you. I don't. No one needs me to tell them that. But smoking while living with HIV is downright terrible, and for reasons that we don't always know. So that baseline risk has to be addressed, and statins is just one of the things. So let's consider all other modalities.
Okay, thank you. Many of us were very interested in the data you showed on switching from to another regimen if insties resulted in weight gain. And the issue that because most of that weight gain occurs in the first year after using an INSTI, and all of the switch studies to date have enrolled people who'd been on an INSTI for more than a year, it seems like we need to resolve that issue. Are there any studies looking at switching earlier? If you notice someone gaining weight rapidly on an INSTI, switching earlier, does that result in a return to what is the normal weight for that person?
Yeah, it's a question that I don't have the answer to. When I talked to John Kurth and who the PR for the Do It study, I asked if they can stratify the data looking at people who were on, since the average duration of INSTI prior to the switch was 34 months, whether they could look at it as subgroup analysis. But I believe that there were too few patients to make meaningful conclusions on that. And I am not aware of other studies that have focused specifically on that. I believe people may find it a bit reckless to be making changes within months, but that may be what we need to think about. But I'm not saying that it's going to work. I'm just saying that it hasn't been tested enough in the studies that I've seen to find out whether that would work.
Okay. Another question from our attendees. Can you please address the frequency of laboratory monitoring in stable patients living with HIV? And the comment relates to the fact that many of the guidelines continue to recommend perhaps more frequent lab testing than is actually needed in clinical practice for a stable patient. What are your thoughts on that issue?
Yeah, I believe that the participant is probably referring to even the newest guidelines, the DHHS guidelines, are still talking about every 3 months. And for viral CD4, I think it's a little too frequent. And the CD4 count first. I think that the data is abundantly clear that people who are virologically suppressed, when followed over time, there's very little risk that the CD4 count will drop while they remain virologic suppressed. Also, it's important to note that the data exists showing that even while as long as you're virologically suppressed, even with very low CD4 count, risk of OI was virtually nil. Even if your CD4 count is between 100 and 200, you got zero risk of OI as long as you're virologically suppressed. So it begs the question, should we just relax this frequent testing? I totally agree with the listener. But again, we'll see how the guidelines bodies will react.
Okay, and I think I'll end with this is maybe more of a commentary than a question from the audience, but given some of the changes in clinical practice and guidelines with the US administration currently, many patients and providers are feeling that the LGBTQ plus population is more marginalized and having more difficulty with challenges in access to care and treatment information. And do you know about any patient and provider level resources and courses that would be helpful for managing this? And I'll just start by saying this course and the courses offered by IAS-USA are not funded by the federal government, and we therefore are able to include information for people among those in the LGBTQ plus population as well as transgender care. And that will be obvious when I start to review some of the upcoming courses and information and resources available. So I would pay attention to this space in your clinical care armamentarium, because I think there is a lot out there available to you. So we're at the end of our time frame for answering questions, and I'm going to go to our closing discussion. We have a couple of closing slides that will give you information about evaluations and how to claim CME credits and a certificate of participation. And all of those will be emailed after this conference today by the end of today. These are just some of the IAS-USA news and upcoming activities. And I'll just highlight again, the guidelines for prevention and treatment of HIV are also a resource that is offered by IAS-USA, and our ongoing program of information in webinars like this and on our website, Cases on the Web, and other information is available to you through the IAS-USA website. So I want to thank our audience for their participation and attendance at this wonderful event, and thank our speaker for a very broad-ranging and excellent discussion of new information that I hope will keep you all up to date. So thank you, everyone, for your attendance, and we'll go ahead and close our program for today.
Thank you so much, Dr. Benson, and thanks to all the attendees.
Okay.